Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. In this video, I will be explaining you sickle cell anemia. Let's get into the details. Sickle cell anemia is the most common hemoglobinopathies and it follows autosomal recessive inheritance pattern. See, the mutation in the beta-globin gene is seen in sickle cell anemia. It is a substitution mutation. Now, the substitution that is going on here is at the 6th place of beta chain, a codon which is coding for a glutamate is now replaced by an amino acid valine. See, the codon that is GAG, which is coding for glutamate, for an amino acid which is present at the 6th position of beta chain, is now replaced by GTG, which is coding for valine. So the substitution here is adenine in GAG will be replaced by thymine in GTG. So because of this substitution, a hydrophilic amino acid glutamate is substituted by hydrophobic amino acid, that is valine. Sickle cell anemia, it is a homozygote condition because of mutation in both the genes that is coding for beta chain of an adult hemoglobin molecule. And so because of this, since both the beta globin genes are affected, so both the beta globin chains in hemoglobin molecules of an adult hemoglobin will be mutated ones, and that's why patients will be symptomatic and will show signs and symptoms. Whereas sickle cell trait, it is a heterozygote condition where one of the two beta globin gene is mutated. That means one of the two beta globin protein is a mutated one, the other is normal. Because these people will have one normal beta globin chain and one abnormal beta globin chain, that's why they act as a carrier and they are not showing any signs and symptoms. So that's a carrier state there. Whether it is an sickle cell trait or sickle cell anemia, that is whether an hemoglobin is of HbAs or HbSS, sickle cell hemoglobin, it do not interact with binding of oxygen with the hemoglobin molecule. So that's why oxygen binding with sickle hemoglobin is not altered. Now let's look at polymerization of hemoglobin in sickle cell anemia, where both the globin genes are mutated. That's why both the globin in hemoglobin molecules are affected. See, the change here is a replacement of hydrophilic amino acid glutamate with the hydrophobic amino acid valine. That's why hemoglobin SS, it becomes insoluble only when it goes into deoxy condition, because during deoxy condition, this additional valine, which is a hydrophobic one, it will be exposed over the surface, and because of this exposure of valine during only in deoxy condition, so it is acting as a sticky patch and it is going to interact with the other hydrophobic amino acid specially exposed during deoxy condition and make an insoluble fiber. And this insoluble fiber, it will lead to polymerization of hemoglobin molecule only under deoxy condition. This is what happens with the HbSS. Whenever it undergoes a deoxy state, only during deoxy condition, there will be exposure of this sticky patch because of additional valine residue, so thereby leading to polymerization of hemoglobin and making an insoluble fiber in the cytoplasm. Whenever the sickle hemoglobin is oxygenated, when it is taken to the lungs, when hemoglobin is oxygenated, at that time, because of change in the conformation of an hemoglobin, because of binding of oxygen, so the sticky patch will be taken out and thereby a depolymerization process will happen. So this polymerization and depolymerization will be going on in a sickle hemoglobin molecule present in the red blood cell. Some of the provocative factors that leads to sickling and polymerization process. Because of this insoluble hemoglobin fibers that forms in the sickle hemoglobin, especially when hemoglobin goes into deoxy condition, so it will lead to changes in the shape of red blood cell. So the insoluble fibers will lead to sickling of the red blood cell, and the red blood cell appears that sickled shape, and this sickled red blood cell is an abnormally shaped red blood cell, and it can be taken out of the circulation by a spleen. So the splenic sinusoids will take up sickled RBCs out of the system and destroy them. That will lead to hemolysis and loss of hemoglobin, leading to anemia. So decrease in the hemoglobin content of blood is referred as anemia, and this anemia is because of lysis of red blood cell, because of sickled shape, which is an abnormal shaped red blood cell. So because of the sickling, there is decrease in hemoglobin. That is why the name of the disease here is called as sickle cell anemia. Some of the provocative factors for polymerization of hemoglobin or anything that will lead to hemoglobin into deoxy condition, and that is fever, infection, excessive exercise where there will be deoxygenation process and that leads to polymerization, anxiety, abrupt changes in temperature, hypoxia, high altitude and lung diseases where hypoxia is seen. All these are provocative factors which will exacerbate polymerization of hemoglobin molecule and lead to insoluble fiber formation and sickling of red blood cell, and that can lead to increased hemolysis process. This is what happens in sickle cell anemia patients. So here is the figure. It summarizes the changes that are going on starting from the gene level and then all the way until sickling process and even the microvascular obstruction. So beta-globin gene 6th codon is GAG, which is coding for glutamic acid, glutamate, which is a normal adult hemoglobin. So whenever there is a replacement of GAG with the GTG, where glutamate is replaced by valine, so it leads to abnormal type of hemoglobin, that is hemoglobin S. And if both the beta-globin genes are mutated, so both the beta-globin chains in a hemoglobin molecule are abnormal type, and these hemoglobins, especially when they go into deoxy condition, they polymerize, and when they polymerize, they become insoluble fibers in the cytoplasm, and that leads to sickling process, and the sickled red blood cell can cause microvascular obstruction as it is shown here in the figure, and also sickled red blood cells are destroyed by the spleen, and that leads to rapid hemolysis process, and loss of hemoglobin leads to decrease in the quantity of hemoglobin in the blood. That causes sickle cell anemia. Now the sickled red blood cells promote microvascular occlusion, and also it will lead to damage to red blood cell lipid layer because of repeated sickling process that is going on, and also the polymerization causes sickling, and and when red blood cell goes to the lungs where oxygenation is going on, there will be depolymerization process. This repeated polymerization and depolymerization and alteration in the shape of the red blood cell may lead to damage to the RBC lipid bilayer, and that causes influx of calcium. And overall, because of this repeated polymerization and depolymerization, red blood cell lifespan may reduce from 120 days to 10 to 20 days. And RBC sickling will lead to tissue ischemia, acute pain and gradual end organ damage, and chronic tissue hypoxia and microinfarctions may lead to bone pain, and it will lead to other signs and symptoms that we are going to see in later slides. So episodes of ischemic pain with painful crisis can be seen, and ischemic malfunction and frank infarction of organs can be seen because of sickling process. So the flow chart here, it shows whenever arterial partial pressure of oxygen is high, where hemoglobin is in oxy condition, so hemoglobin, it is soluble. Whenever hemoglobin goes into deoxy state, so it will lead to polymerization process, and that leads to sickling of red blood cell and membrane changes, which includes calcium influx and potassium efflux, and that leads to viscous cytoplasm and also sickling of red blood cell. Overall, it will give rise to capillary and venule occlusion, and that capillary venule occlusion will lead to microinfarction, ischemic tissue pain, ischemic organ malfunction, and even autoinfarction of the spleen. And also on the other side, because of repeated sickling process, red blood cell lifespan will decrease, as I said earlier. So it will go from normal 120 days to 10 to 20 days. And overall, because of rapid RBC lysis, it will lead to anemia, and breakdown of red blood cell releasing hemoglobin will increase bilirubin levels, and that will lead to jaundice, and excess bilirubin in the gallbladder will predispose to calcium bilirubinate stone formation, and that's the gallstones there. And also because of microinfarctions, especially in the lower limbs, it will lead to leg ulcers. So these are some of the consequences of sickling process, especially when hemoglobin goes into deoxy state, which leads to polymerization of hemoglobin in the cytoplasm and leading to subsequent alterations in the red blood cells, and later leads to microvascular occlusions and the consequences of microvascular occlusion. Some of the signs and symptoms that we see here in sickle cell anemia starting from the childhood is acute and chronic pain due to microvascular occlusion and microinfarctions. The most common clinical manifestation is vaso-occlusive crisis. Pain crises are the most distinguishable clinical feature of sickle cell anemia. Bone pain due to bone marrow infarction is seen, and this is often seen in long bones of the extremities. Chronic hemolytic anemia will occur, and this will lead to elevated bilirubin and jaundice. And also frequently patients with sickle cell anemia will show calcium bilirubinate stones. Patients will also show aplastic crisis, and this is because of serious complications due to infections with parvovirus B19. Splenic sequestration is seen in sickle cell anemia. It is because a spleen is congested with trapped red blood cells which are sickle shaped, and also which will flow slowly in the splenic sinuses and also in the reticuloendothelial system. And because of this, spleen enlarges during the first year of life, leading to splenomegaly, and later spleen will undergo fibrosis over a time, and fibrosis induces autosplenectomy. So autosplenectomy is a spleen which is fibrosed and do not have a significant anatomical function, and that is what is referred as autosplenectomy. Sickle cell anemia patients are at risk of infection by encapsulated bacteria like Streptococcus pneumonia, Haemophilus influenza, Neisseria meningitis, and Salmonella. And note that Salmonella is the most common cause of osteomyelitis in sickle cell disease patients, and especially this is in US and Europe population. Patients with sickle cell anemia may show growth retardation, delayed sexual maturation, and also they are being underweight. Patients with sickle cell anemia may show hand-foot syndrome, and this is a dactylitis presenting as bilateral, painful, and swollen hands and or feet in the children. Acute chest syndrome is also seen in sickle cell anemia patients. So, young children present with chest pain, fever, cough, increase in the respiratory rate, leukocytosis, that is increase in white blood cells, pulmonary infiltrates in the upper lobes, and adults are usually febrile and dyspneic. They have difficulty in breathing, and also they will show multilobular or lower lobe lung disorder. Patients with sickle cell anemia may show pulmonary hypertension, and this is increasingly seen as a serious complication of sickle cell anemia. Patients with sickle cell anemia will also show avascular necrosis of femoral or humeral head. This is due to vascular occlusion. And also patients with sickle cell anemia will show signs and symptoms of central nervous system, and the most severe manifestation in that is the stroke or the paralysis. Ophthalmological involvement in sickle cell anemia can be ptosis, that is drooping of the eyelid, can be retinal vascular changes, and also proliferative retinitis. Cardiac involvement can be dilatation of both the ventricles and the left atrium. That is one of the findings you see in sickle cell anemia. And the gastrointestinal involvement can be cholelithiasis because of calcium bilirubinate gallstones. And genitourinary involvement is like kidneys lose concentrating capacity because of microvascular occlusion. Priapism is a well-recognized complication of sickle cell anemia also. And the dermatological involvement includes leg ulcers. So these are some of the signs that are seen in sickle cell anemia patients. Coming to diagnosis of sickle cell anemia, typical clinical picture of chronic hemolytic anemia, vaso-occlusive crisis indicates sickle cell anemia diagnosis. But electrophoresis, it confirms the diagnosis with the presence of homozygous hemoglobin. As you see here in the hemoglobin electrophoresis, so 3 samples are applied at the cathode side, that is hemoglobin AA indicates normal hemoglobin, hemoglobin AS indicates a sickle cell trait, and hemoglobin SS indicates sickle cell anemia, where both beta-globin chains are mutated. Now, when the electricity is applied, the bands will move from cathode to anode. In HbA, normal adult hemoglobin, both the beta-globins are normal and they contain glutamate. So, since it has got a negative charge, it will move all the way towards the anode. Whereas, sickle cell trait patient will show 2 bands. One of the band is stopping in the middle because it has got valine. It is a sickle cell type of beta-globin chain. And the other beta-globin chain is normal, so it moves normally all the way towards the anode. So you see 2 bands there. One is stopping in the middle and the other goes all the way towards the anode, just like normal adult hemoglobin. And in the sickle cell homozygote condition, sickle cell anemia patient, hemoglobin, both of them are mutated. So both the beta-globin chains contain valine, so it stops in the middle. So this is the electrophoretic pattern of hemoglobin, and this will confirm the presence of homozygous hemoglobin, that is hemoglobin SS. So this particular diagnostic feature helps in the diagnosis of sickle cell anemia. So in this test, when a blood smear is exposed to low oxygen tension by adding a reducing agent like sodium dithionite, the red cells respond by changing to sickle shape, and this is what is referred as sickling test. Now another test that we can do is solubility test. In this test, when a sample of hemolyzed red cells is exposed to an anoxic condition by adding again a reducing agent, and opalescence is observed indicating the presence of less soluble deoxyhemoglobin. So these are some of the tests that can use in the diagnosis of sickle cell anemia. So we have hemoglobin electrophoresis, which confirms the diagnosis. We can do sickling test and also solubility test. Let's look at treatment. Treatment focuses on hydration, oxygen therapy, reducing the pain like analgesia, prophylactic penicillin to prevent infection, and sometimes transfusion to manage vaso-occlusive crisis, chronic pain syndromes, chronic hemolytic anemia, and prevention and treatment of infections. Some of the drugs that are used in the treatment of sickle cell anemia. So the first one is hydroxyurea. Hydroxyurea, it's an anti-metabolite. It is therapeutically useful because it increases circulating levels of fetal hemoglobin, thereby decreasing the sickling process. So when our sickling process is decreased by the use of hydroxyurea, so it decreases the frequency of painful crisis in sickle cell anemia patients. Hydroxyurea also reduces levels of circulating leukocytes, which will decrease the adherence of neutrophils to the vascular endothelium also. Otherwise, hydroxyurea is originally designed as an anti-metabolite for treatment of certain tumors. Hemoglobin oxygen affinity modulators like voxelotor can be used, and these drugs will prevent sickling process. P-selectin inhibitors like crizanlizumab is used to prevent vaso-occlusion. Opioid analgesics can be used to alleviate ischemic pain crisis like oxycodone aspirin combination, methadone, morphine sulfate, oxycodone acetaminophen combination, or fentanyl or codeine. So this type of opioid analgesics can be used to alleviate ischemic pain. Non-steroidal analgesics can also be used to decrease the pain, such as ketorolac, aspirin, acetaminophen, ibuprofen. These things can be prescribed. Tricyclic antidepressants can also be used to decrease the pain, like amitriptyline, which is a tricyclic antidepressant. Antibiotics can also be used to prevent infections like cephalosporins, which is like cefuroxime, or amoxicillin clavulanate, azithromycin, cefaclor. This type of antibiotics can be used. Vaccination can be done to protect against encapsulated bacteria. Endothelin-1 receptor antagonists can be used. Example, 𝗠𝐴𝐵, which will prevent red cell adhesion to the endothelium. Phosphodiesterase type 5 inhibitors like tadalafil can be used to prevent priapism. Transfusions for sudden severe anemia due to acute splenic sequestrations, parvovirus B19 infections, hyperhemolytic crisis can also be done. Erythrocytophoresis can also be done. It is an automated red cell exchange procedure that removes blood that contains sickle hemoglobin from patients while simultaneously replacing the same volume with the packed red blood cells which are free of sickle hemoglobin. So this type of treatment is called as erythrocytophoresis. And lastly, stem cell transplantation and gene therapy can be done, and this can be a curative therapy. So these are different modalities of treatment that is tried in the treatment of sickle cell anemia and also in prevention of the complications arising from sickle cell anemia. Coming to other structural hemoglobinopathies, the first one is hemoglobin C trait, which is referred as HbA(c). Now coming to hemoglobin C disease. In hemoglobin C disease, both the beta chains are mutated, where at 6th position glutamate is replaced by lysine. So it is a milder disease that generally do not lead to any signs and symptoms. Patients generally remain asymptomatic for most part, but some patients may experience a mild chronic hemolytic anemia, splenomegaly, cholelithiasis, and pigmented gallstones which occurs at increased frequency. These are some of the signs that may be seen in some of the patients. Other than this, largely hemoglobin C disease patients remain asymptomatic. Coming to hemoglobin SC disease. Hemoglobin SC disease is a compound heterozygosity condition where one of the beta globin has a sickle cell mutation, where 6th position glutamate is replaced by valine. Other beta globin is of HbC type, where glutamate is replaced by lysine. So there will be equal amount of HbS and HbC found in the red blood cell. Patients will show clinical signs and symptoms similar to sickle cell anemia, but it is less severe. Proliferative sickle cell retinopathy and avascular necrosis of femoral head is more common in this disease than sickle cell anemia. Coming to sickle beta 0 thalassemia. In sickle beta 0 thalassemia, one of the beta globin is of sickle type, that is 6th amino acid in the beta chain is where glutamate is replaced by valine, whereas the other beta globin is absent. So that means more than 90% of hemoglobin in this patient's red blood cell is of sickle type. Patients will show splenomegaly and vaso-occlusive crisis. Whereas in sickle beta plus thalassemia, one of the beta globin chain is of sickle type, whereas the other beta globin quantity is decreased. So in this patient's red blood cell, more than 60% of their hemoglobin is of hemoglobin S type or sickle type. Still, patients will show splenomegaly and vaso-occlusive crisis. Now, these are the other structural hemoglobinopathies that we see other than sickle cell anemia. So, we have seen hemoglobin C trait, hemoglobin C disease, where both the beta globins are of C type, and then we have seen hemoglobin SC disease, which is a compound heterozygote disorder, and also we have seen sickle beta 0 thalassemia and sickle beta plus thalassemia. These are all the collection of disorders where structural changes in a hemoglobin molecule will go on, and especially it's a qualitative change because of a substitution mutation mostly going on in the beta-globin gene, especially at the 6th position of beta-globin, where glutamate is replaced by valine in one of the beta-globin chain, leading to sickle cell trait. If it happens in both the beta-globin chain, it leads to sickle cell anemia. If it happens in the 6th position of beta-globin chain, where glutamate is replaced by lysine, that leads to HBC trait if it happens in one beta-globin chain. If it happens in both the beta-globin chain where glutamate is replaced by lysine, that leads to HBC disease. Or if one beta-globin chain, 6th position, glutamate is replaced by valine, other beta-globin chain, 6th position, glutamate is replaced by lysine, that leads to HBSC disease, which is called as compound heterozygote condition. And also, in sickle β-0 one of the beta-globin chain is of sickle type and other beta-globin chain is not there. Or in sickle beta plus thalassemia, where one of the beta-globin chain is of sickle type and other beta-globin synthesis is less or decreased. So all these are different types of qualitative mutations that will lead to sickle cell anemia and the group of similar disorders. So that's all about sickle cell anemia. I hope this video has helped you in understanding this very important disorder, that is sickle cell anemia and the related disorders. Thank you.